before I get into the ins and outs of this, that IV to PO is an important topic for antimicrobial stewardship. It's an activity that's endorsed by national authorities on stewardship. So the CDC core elements of antibiotic stewardship programs in 2019 mentioned IV to PO conversion several times throughout the document, and highlighted this as a provider-based, pharmacy-based, and nursing-based intervention that can be done. Antibiotic timeout is recommended at about day 2 or 3 of therapy to assess for this. Pharmacy is encouraged to do automatic protocols for antibiotics with good bioavailability, and nurses are encouraged to prompt conversations with other healthcare team members to get that switched over. And then the other big national guideline from IDSA on implementing antibiotic stewardship programs in 2016 noted that programs should implement programs to increase the timely transition of patients from IV to PO, and saying that this should be integrated into routine pharmacy activities, and also with the ultimate goal to implement these strategies to identify candidates for oral therapy and reduce need for long-term catheters and outpatient IV therapy. So before we get into some more details, I wanted to take this moment to highlight the work of Dr. Ramirez, who at the turn of the century was doing a lot of work for IV to PO stewardship. So prior to Dr. Ramirez's and other pioneers in the field, 7 days of IV therapy was standard treatment course for inpatient, hospitalized patients with community-acquired pneumonia. So this study that I have here is a prospective observational study of 200 patients that were hospitalized with community-acquired pneumonia. And these patients were switched to oral when they were clinically improving. And this was defined basically as improving of symptoms of pneumonia and the patient's able to take oral medications. So if they were clinically improving, then they were candidates to be switched. He found that 44% of the patients of that cohort did have clinical improvement within 3 days and had no barriers to discharge at that time. So for that cohort specifically, we saw a pretty short length of stay of 3.4 days, pretty high patient satisfaction. So patients did not perceive that they were getting inadequate care just because they were getting out of the hospital faster. So this was great. And also saw a high clinical cure rate at the monthly follow-up. So this was a big advancement from 3 versus 7 days for IV therapy. And another study took it a step further and looked at retrospectively at 36 patients that were hospitalized with CAP, but also had streptococcal bacteremia, so a more severe presentation of CAP. We saw that patients who improved and were switched to oral therapy during their initial course were all cured just the same as patients who improved and stayed on intravenous therapy. So basically, these studies kind of show that it was safe to switch from IV to oral as soon as the patient reached clinical stability, even in more kind of severe presentation there. So I wanted to draw attention to some of the high quality evidence that has since kind of came to light over the years as we try to answer this question of can we do oral safely instead of IV? And so we've been pushing the boundaries and testing this with various infections and various antibiotics. The 2 biggest landmark trials that I'll mention here are the OVIVA trial, which looked at bone and joint infections, and POET trial looked at enteritis. So these are often considered our most severe infections that usually require long antibiotic courses from weeks to months sometimes. And what they saw is that after an initial period of IV therapy, the group that was switched to oral had pretty much the same clinical outcomes as the patients who were kept on IV for the full course. So they found non-inferiority there. And they also found that there was shorter length of stay in the group that had been treated with the oral options. So all in all, a recent meta-analysis looked at all it could find for randomized controlled trials on this topic of IV to PO. They found 20 randomized controlled trials, and they did not find a single one of those that showed superiority of IV over PO. So in aggregate, the evidence is very clear on this topic. IV is just as good as PO. And the question now is, how do we put this into practice? Because after all, we wouldn't have IV therapy if it wasn't helpful in some way, in some situations. So go ahead and highlight those. So what it comes down to is this kind of risk versus benefit equation. I'll briefly touch on the risk here. So we know that with IV therapy, we're going to have catheter-related adverse events, whether that be clots or local or systemic infections. This is an intrinsic risk with IV therapy that we don't have with oral therapy. And then the other kind of disadvantage here is several studies, some of which I mentioned, have found increased length of stay and costs in patients who are receiving IV versus oral therapy in a patient. And then the benefit of intravenous therapy can be roughly put into two groups of the benefit of avoiding enteral route and also favorable pharmacokinetics with IV that we don't have with PO. And I'll go into those benefits a little bit more in depth here. So the first one is avoiding the enteral route. So when we think of when this is important and when we need to do IV versus oral, these are some things that come to mind. So GI pathology, basically anything that interferes with GI absorption, such as gastroparesis, where the stomach contents are not emptying properly, or a bowel resection, maybe even severe diarrhea. These things can impact absorption and make it suboptimal to use oral route for that reason. Vomiting and mucositis is another reason that we might prefer IV route. Vomiting is kind of an obvious one, and then mucositis with painful ulcers of the mouth and esophagus can certainly prevent oral administration for those patients. And then oral GI absorption. I separated this from GI pathology because sometimes patients don't have anything strictly abnormal with the GI tract, but they might be having a syndrome such as shock that might impair the blood flow to the GI tract and make that absorption not happen as it normally would. So that's one scenario in shock where we would be using IV antibiotics, partially for that reason. And then for drug interactions with enteral feeds, this is a specific one and sometimes gets forgotten, but certain medications such as fluoroquinolones and doxycycline, they bind to certain cations such as magnesium or calcium, and these cations are present in enteral tube feeds. So patients who, for example, are on continuous feeds, they never kind of get a break from those. It might not be the best idea to give these medications enterally, since their efficacy may be reduced. So another reason the IV route may be beneficial instead of oral is that we have certain favorable pharmacokinetic properties with IV that we don't have with oral. So here, if you look at the graph, the y-axis is just the drug concentration in the bloodstream, and then the x-axis is time. So we can see that with IV therapy, the purple part of the graph, we have a very high peak, and it is a very fast peak, and then it slowly kind of reduces as the drug is cleared. And then for oral administration, we can see that the peak is not as pronounced and it's delayed a little bit time-wise. So just thinking in general about when this would matter. So when we think of having a high peak, in general, high peaks will matter most for antibiotics that demonstrate peak-dependent killing, because not all antibiotics do. But for example, aminoglycosides and fluoroquinolones, those are peak-dependent antibiotics. So theoretically, we would have that advantage there. With aminoglycosides, they're only available in IV formulation. So that's a moot point regarding this. But for fluoroquinolones, you could theoretically have an advantage of getting that higher peak. However, we have to be careful here and not to assume that with oral administration, we would have an inadequate peak. And then when fast peaks matter, so when does the time really matter for this? So generally in infections that are rapidly progressing and are considered infectious diseases emergencies, such as septic shock, meningitis, necrotizing fasciitis, these are all serious infections where we want to get the drug in as soon as possible and active as soon as possible. So that's when IV would be preferred for such infections. So another way IV can be favorable pharmacokinetically is in terms of bioavailability. And bioavailability, the definition of that is simply the fraction of the administered dose which gets to the bloodstream unchanged. So if we think about IV administration, 100% of what we are administering gets to the bloodstream, so it's 100% bioavailable. However, with oral antibiotics, usually our bioavailability ranges quite variably depending on the antibiotic. So we usually get less than 100% drug absorption. But then this kind of begs the question of how much is enough, and can we kind of compensate for the lower bioavailability? And I'll get to that in a couple of slides here. So let's talk about how we can group antibiotics based on bioavailability. In general, we think of them as being as high, medium, and low bioavailability. High being 90% or more, medium 60 to 90, and low less than 60. For the low ones, I only included those that we actually use orally. There's plenty of antibiotics that have zero bioavailability, which we would not use for systemic infections, but I did not include them here. So we can see just kind of some general themes to point out. There's plenty of highly bioavailable antibiotics here in that category in the left table there. And then medium and low bioavailability as well, many options there. But something to point out, one, to draw attention to the beta-lactam class, because beta-lactams are, I would say by far the most common antibiotic class that we use. And there's many different beta-lactam drugs within that class. And sometimes because of that kind of overarching categorization, we get kind of misconceptions about certain things about the beta-lactams. So for example, we can see here we have cephalexin being a highly bioavailable beta-lactam, whereas amoxicillin and penicillin are more medium, and then there's many more in the low category. So they're kind of all over the place in terms of beta-lactams are not necessarily always low or always high. And we can run into trouble with this when we try to categorize beta-lactams as one class. But this is important to remember because beta-lactams are usually one of the kind of least harmful classes of antibiotics that we can use. So on this slide, I have an example of kind of how this can come into play in practice. This is a very, very simple example of how bioavailability can drive our decision on whether to use IV or PO. So for example, if you have a Pseudomonas aeruginosa bacteremia and you have this isolate come back and it's not susceptible to pretty much everything except for meropenem, And meropenem only comes in IV formulation. It does not have good bioavailability. So that is kind of what we're stuck using in this case. And the only other option we could have had is ciprofloxacin, which does come in oral, but it was resistant in this case. So a very simple example of how sometimes, even if we want to do oral, we can't based on the organism. I briefly wanted to touch on conversions from with IV to PO. Some antibiotics have, like I mentioned, very high bioavailability, and usually the ratios for switching for these are 1-to-1. But then things get a little bit trickier with medium bioavailability antibiotics and also low bioavailability antibiotics. So for example, for ciprofloxacin, we know that it has 70% bioavailability, and the standard IV dose is 400 milligrams. When we get this IV, this all reaches the bloodstream, but when we, if we want to convert to oral, we usually increase the dose to 500 milligrams orally. So we get approximately the same amount reaching the bloodstream there, accounting for that lower bioavailability. So one last example of how kind of pharmacokinetics can affect how we dose IV versus PO antibiotics. Azithromycin is pretty unique in its PK/PD. It's used for a variety of infections, including pneumonia, ear infections, sexually transmitted diseases. But the interesting thing with azithromycin is it's 37% bioavailable. However, in practice, we use a 1-to-1 IV to PO conversion ratio. And this is interesting because, I just showed a previous example where we would adjust the dose to make up for that lower bioavailability. But in this case, azithromycin is unique because one of the hallmarks of this drug is it's very widely distributed into tissues, concentrates very well in certain tissues. So this table here is an example where we have various tissues like skin, lungs, sputum, and we can see in the yellow box there on the right, for example, in the lung, we get more than 100% ratio of the tissue to the serum. So there's a lot more drug that ends up in the tissue than does in the serum. And this kind of concentration is important because that's usually that's where we want the drug to be, is in the tissue where our infection is. And that's very good despite the low bioavailability. Something else that's interesting with azithromycin is it likes to concentrate in the white blood cells. So this graph, the second graph here with the black bars shows infected cells or infected tissue. And we can see that there's a lot more azithromycin concentrated here since white blood cells concentrate in the infected tissue. So overall, we can see how pharmacokinetic and pharmacodynamic properties might influence kind of this conversion. So thinking about all of those scenarios together, we can kind of go back to this diagram of risk versus benefit and think about it this way. So the risks usually are going to outweigh the benefits when the patients are able to take oral medications without issues and pharmacokinetics is not a concern. That wasn't an all exhaustive list of scenarios where IV may be beneficial, but this is just a framework kind of to think about this. So when we don't have those benefits, then all we are kind of left with is risk. So some key takeaways here, IV antibiotics are not intrinsically stronger than oral antibiotics. There's some high quality evidence that does not kind of show superiority of IV versus PO. IV route carries risk, as we know, with catheter infections and increased length of stay. And also the bug, the pathogen that we're treating, doesn't care how the drug gets there. So whether you're giving the drug IV or you're giving a proper dose of oral antibiotic, the pathogen gets exposed to that antibiotic just the same. And then conversions, I had a couple examples there. They're not always intuitive. Usually there's protocols in place at various institutions that can help guide this process, but always asking a pharmacist for an accurate conversion is recommended. And then last but not least, assessing patients for oral eligibility frequently should be a priority for us. You know, whether it's pharmacist, provider, or nurse, nurses are often the most aware of when a patient is ready for oral therapy. So they're in a really good place to initiate discussions about this. But just keeping this in mind and assessing this daily would go a long way for IV to PO stewardship. And that concludes my presentation. Thank you all for joining. I welcome any questions and discussion.
Thank you. Thank you, Elena. That was very good. And I think, you know, your key points were a great reminder. We tend to think that only the IV antibiotics are the important ones, are the most impactful. But then when we're thinking about what are our interactions with patients, how do we make sure that we continue antibiotics uninterrupted? You know, those are the, you know, beyond making sure it's the right one, the right drug, the right bug drug combination, but then making sure that our follow-up process makes sure that they get to the patient and we're not missing doses and making those kinds of errors. That becomes equally as important. So thank you very much. And so if you have questions, put those in the chat. And Dr. Ramirez, I don't know if your video or your audio returned.
Yes.
Are you back? Okay, great. I know you always have some great questions.
Do you have any questions in the chat, Ruth?
Not yet, not yet.
Elena, a great presentation. Thank you. Then you mentioned initially that when the patient is clinically stable, you can switch from IV to oral antibiotic. What criteria would you recommend for someone that is in another institution? Say, well, yes, I would like to start doing this. When do you think that is this appropriate time for go from IV to oral? Is based on number of days of IV antibiotics, based on how the patient responds? What would be the advice?
Yeah, so that's a really good question. So how do we make that determination of when we can deem a patient clinically stable? I think it's going to vary by patient, but some general kind of rules of thumb that I think about are definitely the sepsis criteria. If a patient presented in a septic picture, seeing that those criteria are no longer being met, so that could definitely signal that they may be ready for an oral conversion, and also, you know, those same things about kind of being able to take oral medications and maybe having their symptoms resolve and those sepsis criteria resolve. That would all be kind of indicative of a patient who's ready to switch.
Very good.
Hey, this is Melissa. I just wanted to share that when I was working as a hospitalist, I took care of children. For the kids that had hematogenous osteomyelitis, we ended up putting in place very specific criteria prior to allow them to switch to oral antibiotics. In the case of those children, they had to do at least 72 hours of IV therapy before we could consider, but we had to see clinical improvement. So not resolution of all the problems, but at least clinical improvement. So, you know, starting to walk on the leg that they'd refused to walk on or moving a limb more. And we had to see at least 2 consecutive decreases of their inflammatory markers. So I think that would be important in a hospital to have pretty clear-cut criteria before you would consider switching over to that oral antibiotic.
Yeah, that's a great point. And at the Norton kind of pharmacy department, we have a protocol to be able to switch from IV to PO. And one of those things that we assess for is having a minimum of 24 hours of IV antibiotics as one of the kind of criteria for being able to switch.
Elena, there are several guidelines for for management of patient hospitalized with infections. And there's always the question, how much of the microbiological workup you're supposed to do. There is some discussion, even the patient gets better with pneumonia, are blood cultures necessary or not? In an attempt to decrease cost, we are using less and less microbiological workup, even though this is questionable. But the fact is that it's not unusual that the patient is getting better, and we look at the microbiology, and the microbiology is all negative. Then what advice do you have in a patient that infection is getting better? Again, there is no fever or whatever is the site of infection, the signs and symptoms are getting better, but I don't know what I'm treating.
Yeah, that's definitely a conundrum that we in stewardship face a lot, where we don't have the optimal information to make that assessment. For example, sputum cultures are great to have, but sometimes they're not acceptable for culture, and you get in a pickle where you don't have enough information. That's definitely something that we deal with. And I think in those scenarios, definitely that clinical improvement, the resolution of sepsis, resolution or improvement of symptoms can guide that kind of empiric de-escalation almost. And I think we do that kind of on a case-by-case basis, where we try not to treat, for a full course with IV broad antibiotics just because we don't have enough information. Definitely a case-by-case kind of decision, but in those cases, I think there are opportunities to de-escalate.
And when you don't know the pathogen, and again, these are all questions that we get whenever we try to do the switch therapy in institutions that don't have an ID pharmacy with experience. When you go from IV to oral, in what patients you try to maintain the same spectrum of IV? Because sometimes the IV, as you alluded, Elena, the patient arrives, looks like he's in shock, and in the emergency room, they start broad spectrum antibiotics. And then in 2 days, 3 days, the person is a different person, and we maybe feel confident. But do you go with oral antibiotics, always trying to maintain the same spectrum? The patient goes on vancomycin and piperacillin, tazobactam, and this and that. Then you have to use 5 oral antibiotics to maintain the same spectrum, or when do you feel confident that you can go from switch from IV to oral at the same time de-escalate with the oral antibiotics? Do you have any general advice?
Yeah, I think this happens a lot, where a patient comes in and just the severity of the presentation kind of forces that kind of broad spectrum treatment up front. I will say that my decision on whether to kind of de-escalate that depends on a couple of things. It depends on the patient's risk factor for having perhaps a more drug-resistant organism. So I know we're doing away with the HCAP kind of diagnosis, but still those kind of bigger risk factors, such as hospitalization or IV antibiotics in the last 90 days, that could, sway me away from potentially de-escalating if the patient is not, or if they're improving slowly. However, as we get, cultures back, we get negative blood cultures, we get negative sputum cultures, I feel like that is a time where I would de-escalate the spectrum, as well as, potentially switching to oral.
There you go. Ruth, the problem is I can keep discussing this topic for the next 2 hours, but I know that people have other things to do. And Elena probably still say, "Oh, Dr. Ramirez, shut up."
So, well, I think at the very beginning, she talked about that, you did a lot of the really original work in looking at switch therapy. And so I know that is a topic, certainly a topic of interest. And I think more and more of us become interested as we're really trying to broaden our depth of what is stewardship, what is included in this. And I know many of us that have worked in infection prevention think about what our role is. And I think the more that we learn through sessions like this, the more that we understand how broad really our role is in stewardship and in working then within our facility. So Elena, thank you for this information. Dr. Ramirez, thank you for the questions. We don't have any additional questions from the chat, but I know that we try to keep everybody true to our 30-minute time. So I appreciate everybody's involvement. I did send out some notices to those of you that are on the chat. If you have ideas for future sessions, we always populate it with ideas that we have, things that we encounter in practice and that are of interest, but I want to make sure that we're not overlooking any gaps. So please feel free to put your ideas in the chat or send them to me via email, and we will see you back then next Wednesday for our next session that I think is going to focus on, if I recall, we're going to focus on some patient safety aspects of infection prevention and control. So we will see you back then next Wednesday.